Hi, everyone, and welcome back to our next episode of ReWalk's Topics in NeuroRehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with Dr. Alberto Esquenazi. Dr. Esquenazi serves as the John Otto Haas Chair of the Department of Physical Medicine and Rehabilitation at Albert Einstein Medical Center in Philadelphia, and is Chief Medical Officer of Moss Rehab Einstein at Elkins Park, as well as the Director of the Gait and Motion Analysis Laboratory, Clinical Director of the Regional Amputee Center, and Chief of the Prosthetic and Orthotic Clinic. Also in Philadelphia, Dr. Esquenazi is Professor of Rehabilitation Medicine at Jefferson University and Adjunct Professor of Biomedical Engineering at Drexel University. Dr. Esquenazi's research focuses on spasticity, gait analysis, limb prosthetics and orthotics, and pioneering applications of robotics for rehabilitation. His talk today will provide an overview on some of the goals, applications, and limitations of robotic interventions in neurorehabilitation today. Hi, Dr. Esquenazi. It's great to see you today.
Thank you. Likewise. Thank you for hosting me today. I'm pleased to be here with you and your audience.
I'm really looking forward to your talk today because you always have such a great way of sort of walking us through some of the more complex concepts in robotic rehabilitation. And you have so much experience with just such a wide variety of different devices for both clinical and research applications. And so I know our viewers are going to really appreciate hearing your thoughts on the role of robotics in rehabilitation practice today, as well as your views on what you think is still needed and where you think things are headed. So to our viewers, we'd actually love to hear from you as well. So if you've introduced robotics into your own neurorehabilitation programs, we'd love to hear about some of the metrics that you use to track and help evaluate the benefits of these particular programs. So we'd love to hear your thoughts, and please don't forget to like and subscribe to this video if you want to hear more talks like this one. And with that, Dr. Esquenazi, I think I'm going to just let you jump right into your presentation.
Thank you very much. I'm excited to do this. And to the audience, thank you for taking the time to listen to this presentation. I hope is of help to you. And I'm really going to be focusing primarily on the rehabilitation of post-stroke patients, which I think it's a large majority of the population that we all see. As you heard, I work in the Philadelphia region, and I'm at Moss Rehab in Elkins Park. Some of the disclosures, just for clarity, although I don't have anything to disclose personally, institutionally, we have a number of relationships, and so they are listed there. So let me get right to the essence. What's the problem? The problem is that we're dealing with patients that have really a multitude of deficits, and particularly acutely, these patients tend to have great difficulty with their mobility. And we know that really the training principles across the years have been focused primarily on developing techniques for selective movement development and strengthening, or what are called neurofacilitation techniques. This not come easy. Therapists have to do lots of effort to achieve this. And what we know is that even with all of this, patients really are not doing what they need to do, which is we want to be sure that they're walking and that they're walking a lot. And so that creates a major challenge. This is data from one of our patients, so I thought I share this. This is a project that we are carrying on. Dr. Chow, who's the lead researcher in this project, decided to measure the number of steps for all inpatients in our units. And what she found is that really patients walk very little. You can see that this patient on day 19 was walking 557 steps in a whole day. And remember, there's supposed to be an intensive rehabilitation program. That's what an inpatient program does. So we clearly can attest that these patients are not getting as much. And of course, what ends up happening is you're in an average, when we looked at a bunch of patients, you're walking less than 500 steps in a day. Not really conducive to all of the things that we need to do in neurorehabilitation. And so we know, I think with lots of clarity now, that Santiago Ramón y Cajal, a famous Spanish neuroscientists had said in the 20s, you know, once your brain breaks, that's it. It's hardwired. It doesn't, cannot be repaired. And he did leave it open to say that maybe in the future, you'll be able to prove that that's wrong. We clearly know now that there is plasticity in the brain, that it is a fundamental property of our neurological system, and that you actually can reharness, you can harness and remap many of those neural connections to promote recovery. And that to do that, really you need to think about intensive, repetitive, task-specific training as a way to regain function. And I like to think about that really you need to use large quantities of practice to attain the benefits that are expected. There are other factors that are critical to motor recovery, things like emotional impact of the activity. Is the patient really enjoying the activity? Does the patient feel it's important? Is there an element of fun? Is there feedback to the patient? All of those are important characteristics. And of course, there is a whole piece of rest, sleep, or even brain stimulation and reward in consolidating motor skills. And those have been laid out over the years, so I'm sure I'm not telling you anything new. So when you think about a locomotor training program, you need to think of this as a method that specifically and repeatedly promotes the desired outcome. In this case, if I'm using the lower limbs, is to really promote walking. And when you do that, you have to keep in mind that there are three major potential limitations. One is that it requires multiple therapists to carry it on. Two, it's usually limited by the endurance of the therapist, not by the endurance of the patients. And if you can have a therapist sustain that for 10 or 15 or even 20 minutes, usually is very difficult to do. And therapists can get injured. They're doing all sorts of incredible things. And so this is an example of a locomotor training program at Moss Rehab. And so you have 3 therapists working with this single patient. You can see why I say that therapists can get injured. There is a lot of effort. You know, when I look at tapes like this, I always wonder who's really doing the exercise here, the patient or the therapist. And so one solution that has become as a potential available is the idea of using robotic devices. And robotic devices have been developed for integration into industry quite well. They are really intended to address circumstances which are difficult, that are unsafe or highly repetitive for humans to perform. And so they tend to work quite well. But the reality is that now we can think about them as devices that we can use in healthcare. And so in my perspective, robotics and rehabilitation are perfect tools because they have really very specific characteristics. So they're very appealing because they can provide well-defined, repetitive functional exercises. You can do that in a consistent and prescriptive manner. The robotic devices can be used really by individuals who have severe weakness. And so they can provide the assistance that the patients need. They can be progressively in increasing demand and complexity of task. And they can be adaptive to the patient needs. And we'll talk about the adaptability in just a second. And then they can be engaging, and in that case, even reduce discomfort because the patients keep really engaged in the activity itself. So I have defined 5 major categories of gait training robotic devices. Briefly, they're listed there: tether exoskeleton, end effector devices, patient-guided suspension systems, untethered exoskeletons, and then joint-specific exoskeletons. And today, my hope is that we're going to be focusing on that last line the most of our attention. So when you look at tether exoskeletons, there are things like the ReWalk or the Locomat, which are used across the world as robotic devices that can provide gait training for patients who are particularly impaired. You could use end effector devices. And so you see examples of them here in which essentially feet are strapped to plates, the plates move the feet, and the rest of the body follows on movements. You could use patient-guided suspension systems. And so here you have 3 examples of that. A system that essentially is giving you suspension, and the patient is able to move around in a more free manner. And then you have this concept that they are tethered. They are meaning that they are based on either a treadmill or a system that is stationary, cannot go anywhere. And even in a system like the one I'm showing you on the right side of the screen, you clearly can see that the patient can only go where the robot goes. So it's tethered to a ceiling track. So let me tell you just a little bit about the benefit of these kinds of systems. Here's a comparative study in which we studied 24 patients with traumatic brain injury of chronic nature. We tested them before in regards to their walking velocity, and then we put them through training in one of the 3 systems, either an end effector device, exoskeleton device, or with manual assistance. And what you see here is that all 3 groups, after 18 sessions of training, had improvement in their self-selected walking velocity. But you can see that particularly for the Locomat, the increase was more significant. And it was in reality the only one that was significant of these 3. So walking is good. If you practice walking, you'll get better at walking. And so this proves that premise, no matter what system you use. There were some other advantages in the conclusions of this study. One is that you can address chronic nature deficits. 2, that you can use devices to reduce the number of staff and speed up the progress of these patients. And so I'll leave it to that. Non-tether exoskeletons refer to this kinds of devices where the patient now can go wherever they want to go, and they are allowed, I'm going to call it more free movement. And there are a variety of these devices in the market or under development. I'm going to briefly talk about the 2 that we use the most here at Moss Rehab, the ReWalk, which is intended for people who are completely paralyzed, and it essentially restores the ability to walk for those individuals. And the Exo, which is a device that is intended only for training. This is not to take home in comparison to the ReWalk. It provides support and assistance for ambulation. And we've published on both of them, and I've listed the publications below. Today, I want to spend a little bit more time talking about this joint-specific exoskeletons. And so they tend to be non-tethered. These patients can go wherever they want to go. On the left side, you have the ReStore. And on the right side, you have this Italian collaboration that will develop a system for the hip. I'm going to focus on the ReStore. And this talks about this soft exoskeleton. Soft because there is no rigid interface. The system uses a soft cloth wrap around the calf. It uses a cable-driven system, as you can see illustrated here. There are actuators that are moving the ankle into dorsiflexion or plantar flexion. And it has a small foot plate that essentially cradles the foot and allows for that movement to occur. What's beautiful about this system is that you can actually optimize the controls. And so on the right side, you see the screenshots of the screen of the controller. And you essentially can apply different forces into dorsiflexion or plantar flexion. And by moving the line or the cursor, you can determine how much assistance you want to provide. And then you have the ability in this system to count steps and do a few other things. And so what you see here is the system. This is the cable in slack motion for the plantar flexion, but the dorsiflexion is taut, and then you can control in a very specific manner that. And that to me is a very important feature of this device, because by really using this control mechanism, you can adjust to the needs of the patient, and that's important. This is one of the subjects that we've trialed on our device. I hope he's going to walk one of these days. Can you walk? There you go. So you see this patient walking. The system right now is off. So you see him with the system on the patient, but not providing any assistance. We shut the system down. Why do we want to walk him like that? Because we want to be sure that the system in itself is not doing anything that may alter the way the patient gait looks like. And so what you see is that this patient has essentially an equinus foot. This is the same patient walking with the system on. And what you see is first, increase in walking velocity. 2, we have now a much more control attitude of his ankle and foot, and he'll come back. Not perfect. We didn't repair his walking and made it normal, but we've produced an improvement. And if you repeat this walking pattern in an improved manner, you're optimizing the walking. The expectation is that the neurological system will learn from that. So this is just brief data from that patient. This is data, temporospatial data. And so the system is off. I've marked it here, walks at 0.80 meters per second. With the system on, the same patient walks at 0.99 meters per second. Reminder, normal walking speed about 1.2 meters per second. So you can see that it's not normal, but much better. You also see that there is asymmetry in the walking. This is right stance, left stance. When you look at this, you start seeing a shift in that asymmetry. You see the periods of double support becoming more symmetrical. You see the step length, which was 70 and 57, starting to get more symmetrical, 72 and 64. So you see an improvement in this. Again, yes, is with the system on. So you're relying on the system, but what you're trying to do is accelerate the process of learning. So in this study, we actually looked at 44 subjects. This was a multi-center trial. 60% of these patients had an ischemic stroke. 41% of them were right hemiparetic. The average age for this group was 54.8 years, and they were about 7 years post-stroke, so a long post-stroke time. 73% of them customarily use assistive devices for walking in the community, and the system was set to provide plantar flexion and dorsiflexion assistance, and what you can see here is 92% of assistance for plantar flexion, 63% for dorsiflexion. And we try not to change these variables during the training session. Patients were exposed to about 5 hours plus minus 2 of total walking time with ReStore, and they had gains in their walking velocity that were greater than 10%. That's when we compare them without the device. And so what you see here, I'm going to focus you. These graphs are very nice because it shows you how many patients move from one category of walking to the next. But if you look at here, this is the pre-post data, and you see about a 10% improvement in walking velocity. And so that's really the important information from these slides. And this was a paper that was recently published with our collaborators, Awad, Francisco, and others. Now, these devices can produce some adverse effects. This is an example of such an adverse effect. Rub dub over the tibia, very simple to address. The system has been modified to cushion that area, but if you need additional cushion, you can just very easily create a foam pad and protect that tibial area. So what's the impact of walking training in function in general? And again, this is from our group here at Moss, unrelated to this study, but related to the intent of increasing walking. What you see is that patients that have minimum practice in walking have a lower functional index measure motor gain. So the more you train walking, the better the patients do. That's really the aim here. And so let me finish by showing you this ambulation guideline that we've developed. We at Moss are fortunate that we have really a large array of robotic devices available. And so what we've done is created really a whole protocol that allows us in acute rehabilitation and then in chronic rehabilitation to look at how we deploy different devices. And what you see is that the ReStore is listed for our overground and our community training program. And it tends to work quite well because it really gets those patients walking more steps, doing it with less effort for the therapist, but the patients do get really a run for their money. So let me summarize by saying that ambulation is an important functional goal for our patients. You know, I haven't seen one patient who has the capacity to walk that says, no, I don't want to learn to walk better. It can reduce comorbid conditions, it can improve quality of life, and certainly it can improve patient satisfaction. There is ample evidence to support the utility of robotic devices for gait rehabilitation, particularly in patients post-stroke and other acquired brain injuries, even in those with a chronic state. And so I want to be sure that you don't dismiss those patients that have not been able to walk or walk well for a long time, because those can still derive benefit from this kind of intervention. Robotic systems are different. They have limitations. They are different in the engineer and design and their control mechanisms and performance. But it doesn't matter. If you use one of these devices, you learn the ropes of these devices. They tend to be of great assistance for patients and the therapy team. So let me acknowledge the subjects who have volunteered really of their time and effort for many of these studies, and the crew here at Moss for all their work, and certainly my collaborators at other institutions. So thank you very much.
Dr. Esquenazi, thank you so much for a fantastic talk and a really fascinating set of insights from your research. To me, it's just so amazing to see so many different examples of applications for robotics and neurorehabilitation and the different ways that they're being used in your clinic as well. Wanted to ask you a few follow-up questions. And the first one is kind of going back to the beginning of your talk. You listed a number of rationales and principles in support of why robotics are beneficial or helpful in rehabilitation. And one of the concepts you presented was that robotics are particularly well positioned to progressively increase that task demand or that complexity of the tasks that you're having your patients do. So I'm wondering if you can talk a little bit more about what that progression looks like for patients at Moss Rehab.
Thank you for the question, and I appreciate the comments. Definitely the idea is that, you know, you don't want to use a constant driver on the patient, meaning if you're always giving them the same amount of support or the same amount of assistance, the system is now not responding to the needs of the patient. And so the ability to constantly change or modify or adjust what I've termed, you know, a dynamic adjustment of the system is what you want in a device. So if you only learn to kick straight balls at a goalie, and that's all you're going to learn. But if I suddenly move you around and position you in different places, you're going to learn to aim differently. So this is the intent. When you walk, you don't walk always on a flat surface that is perfectly even, and there is no change in your walking velocity, and there is no change in the demands of walking. That's what comes out for example, walking with a fixed system, a tether system that has no ability to change the adjustment to the drivers. So you want to be able to do that. And I hope I relayed this when I talked about ReStore and its ability to adjust the amount of support or the amount of assistance that it provides as being an important driver, because you can look at the patient and yes, the first day you may need to provide a bit more assistance, but maybe by day 3, you may be able to do less. And you want to be able to really adapt to that. That adaptability is quite critical in the development and the engineering of robotic systems.
I also noticed that a lot of the studies that you presented, one of the things that you really highlighted and measured for subjects in those studies was the step counts as one of the outcomes that you looked at, and particularly in the acute care setting. So I'm curious, in your opinion, would this be your recommendation as one of the top priorities for therapists to focus on when they're evaluating the effectiveness of their own acute rehab interventions? And then I guess to tack on a second question here, would you consider that to be the priority throughout all phases of rehab, or is that more specific to the acute phase?
That's thank you for that question. It's an important question because this really opens the door to talk about objective of treatment. And so step count is essentially a metric, not an objective. So you're using that to say, am I putting in enough steps so that I can get to my main objective? And the objective should always be get the patient to walk better, to walk faster. So, you know, there's a very nice study that was done many, many years ago on how long does it take to cross a street. You know, the red light is actually usually set so that you can cross the length of the street within a certain period of time, which puts you to walking at about 0.6 meters per second. So about half of normal walking. So if you walk below that, you can't cross the street. Or if you try to cross it, the cars are gonna be honking at you or risk being run over, which then will put you into other types of problems. But the idea here is you want to be able to measure what the outcome is, not what the actual measure of the stepping is. Now, we use step measure because we are trying to be sure that we are putting in enough of the mechanism that will end up producing that goal. And many of the acute patients, the acute post-stroke patients, cannot walk long distances. So you cannot measure velocity unless they can do that. So that's why we use step count as a way to get there. My preferred measurement is number 1, walking velocity. That's a good outcome to measure. Number 2, symmetry of walking. So if you see an increase in walking velocity and you see an improvement in symmetry, you know you are actually making the patient better.
Great. So I think if I can just recap, in the early stages, you're using step count as more of a proxy for the dosage of therapy that you're providing. But as they're able to achieve more of that walking, then you can start fine tuning and looking at things like velocity and symmetry as your objectives.
That's correct. And so if you look at the ReStore device itself, you can actually measure in the ReStore a 10-meter walk test. So you can do that and it will give you a calculated walking velocity. But you need to be able to walk 10 meters. If you're in acute rehab, you know, where the patient needs 3 people to just take a few steps, it makes no sense at that point.
Makes sense. And then speaking of ReStore, you know, it was really great to see the video from your work on the clinical trial. I think so often we only really get to see the data, so it's nice to actually see some stuff in action. And I'm curious to hear, you know, since Moss Rehab was one of the first centers from the clinical trial to purchase a ReStore for clinical use, I'm curious if there were any results or anecdotes from your work on the study that have helped to since then inform your clinical use of ReStore.
No doubt that having the opportunity to have trained our therapists in the research development facilitated the adoption of ReStore as a clinical tool. That doesn't mean that you have to be a researcher to get it into the clinic, but it just made it easier. It also has allowed our therapists to understand what's the perfect role for ReStore. When should you really think of ReStore as a device to try? Because it's a training device. It's not something a patient is going to take home. It's not something a patient is going to be using on weekends. It is intended to be used in the clinic. And so what is it you're aiming from this therapy? And that is, number one, again, training that more normal walking pattern, achieving symmetry of walking, increasing walking velocity. So that's what you're doing. You are resetting the neurological system for a more optimal walking pattern. And so I think that our therapists had benefit from having that way of thinking, which comes from not only the research work that we've done, but really the clinical deployment of all of the technology that we have here at Moss Rehab.
Great. You know, and I think you made a really great point about, you know, a lot of what comes from the experience is really understanding the role for each of these devices. And one of the things you concluded with in your slides was that really great workflow chart that you guys use to show how patients sort of progress through their therapy at Moss Rehab. So I'm curious, when you're evaluating patients and you're developing that individualized treatment plan, how do you determine whether a device will be useful, when you want to introduce robotics, and then I guess more specifically, how do you choose the right device for that individual patient?
You're right that diagram can be overwhelming when you look at it, but it's really the great work of our therapy team who decided to really sit down and say, here is all of the array of tools that we have. Not different than when you try any other array of tools that you have at your disposal or pharmaceuticals that you have at your disposal. You look at all of them, you understand them, and then you say, okay, what's the indication for this? What are the limitations for this? And so they've really laid it out very nicely. So the intent of using a device is not different than when you use any other tool in your armamentarium, which is, how can I make my work more efficient, do it more effectively? And so that's the first part of the analysis. If I have a tool that can help me with that, let's use that. Remember that, you know, if you're just trying to tell a patient, I want you to stand in place and march for half an hour, the patient is likely not to do that. But if you say, let me place you into this tool, we're going to be able to walk and do more of this activity, make it engaging, the patient can see the results, all of that is going to trigger this greater motivation for the activity. Two, if every time I have to get you to walk, I have to hold your ankle steady and put it in a brace that it's rigid, well, then I'm not developing this normal or more normal gait pattern. But if I have a device that can substitute for the lack of plantar flexion and the lack of dorsiflexion and can make it perfectly timed, then ReStore is the right place to go. So you see how I'm basically flowing into where is the deficit and what is that I want to accomplish with that tool. So that's how I would present it in a simplified way.
Great. And we'll actually include links to all of those resources that Dr. Esquenazi mentioned, as well as the references in his talk in the video description below.
Thank you.
Well, thank you so much for a great talk, and thank you so much for your time.
My great pleasure.
And to our viewers, we hope that you've been finding these talks interesting and educational. So don't forget to reach out in the comments section with some of the metrics that you track when you're using robotics in your own neurorehabilitation programs. And please also make sure to like and subscribe to this video using the buttons below. You can also use the comments section to suggest future talks or speakers that you would like to see in this series. We hope that you'll tune in with us again next episode, and take care, everyone.